So we're delighted today to be joined by Professor Mike Robling, who's going to talk to us about doing trials in social care. Mike will be known to most of you actually, but he is the director of the Division for Population Health and Social Care at Cardiff University's Centre for Trial Research. He's part of the inaugural leadership team in the new CARE Centre, which is the Centre for Adult Social Care Research. And he's also an investigator with Cascade, which is the Children's Social Care Research Centre. His main research focus is evaluating complex interventions and with a particular interest in specialist home visiting. As we started a little bit late, I'll just go straight over to Mike and ask him, without further ado, to talk to us about social care trials.
Thank you very much, Claire. And so I'll start sharing my slides. And just to check. Okay, can people see my slides okay? Claire, can you see that okay? Just checking with you.
Can do. Thank you, Mike. Yep.
Excellent. Thank you very much. So thank you very much for the invite, and apologies for the slight delay in getting going this afternoon. I'm a researcher with a strong interest in evaluating complex interventions, and in the last sort of decade, that has featured quite a few studies in social care, both in children and perhaps to a lesser extent in adult social care. So in today's talk, what I really want to cover are some thoughts about undertaking trials in social care settings, and because I guess my main experience has been in children's social care, I will probably draw on examples from that setting rather than adult social care, but hopefully some of the messages will be applicable to both. So I'll talk a little bit about trials in social care, and in particular about developing and doing better trials in that setting. I will touch on, what are the consequences when trials fail, or if they fail to produce a definitive result, because it's something that I've discussed with a couple of colleagues relatively recently. And also where you might go if you want to get some more support on undertaking a trial yourself in either children's or adult social care. So what are the resources? What is the expertise available locally, and how you might get on board with getting that support. So, but a question that's sort of raised on with me and with my colleagues is about the place of trials in social care, and there has been a perception, an enduring perception, really, that randomised control trials are actually relatively rare in social care settings, and also there has been a degree of resistance to the use of randomised control trials in that setting. And I'm not going to answer all the questions about the appropriateness or otherwise, or the value of social care's or trials in social care, but it's worth just perhaps looking at what other people have said on this topic. And in 2015, Bruce Tyre was responding to perceived views that randomised control trials are both impractical, inappropriate, unethical, and rarely undertaken. And in the paper that he published on this topic, he undertook a not quite systematic review, but a fairly structured review of experimental designs used to evaluate interventions or services in social care, and found actually quite a large number of studies that had been published, with the first one that he found being in 1949. So actually, I mean, that number is still small compared to perhaps clinical and public health context, but nevertheless, it does demonstrate that there is actually quite a lot of work going on out there in the world of social care using trials methodology. But it's also worthwhile as a methodologist who works on randomised controlled trials, understanding the values and the perspectives of those people that you would want to be working with in designing and delivering a trial. And my colleague from Cascade, David Westlake, wrote about two trials that have recently been reported. The first, one of which was the social workers in school trial, and secondly, a randomised control trial of an approach called family group conferencing, published by Sarah Taylor earlier this year. And family group conferencing is an approach to involving families in important decisions made about the ongoing care of that family within who have been referred into children's social care. And in fact, in the trial, they found that that actually children who had been allocated at random to the intervention to receive a family group conference were less likely to have children in care 12 months after the onset of pre-proceedings. So actually demonstrated a positive result in terms of the positive outcome for families who had been recipients of that intervention. But some of the commentary that had been written about that trial, both pre and during the trial and subsequently, was that it shouldn't really have gone ahead because access to a family group conference is actually a right for families. So this is something that should be done anyway. And actually, family group conferences are relatively common across the UK. So it's probably a rarity where authorities don't provide family group conferences. So accessing a family group conference is a right and an end in itself. And the idea that you might withhold a family group conference for families through random allocation to, in this case, test effectiveness is seen as wrong. But it's not my position, I guess, to debate whether it's wrong or not. But one of the consequences of this trial will be that access may increase. So access and the availability of family group conferences may well increase, which would be a positive outcome. But still, people may be concerned that decisions about increasing or continuing to provide access to family group conferences on the basis of outcomes versus rights is actually problematic. So it's just worth recognising that where we might want to be randomising in a trial, there may be some challenges that practitioners and others in the sector perceive to be important, which we will have to work with our colleagues to address. But of course, there are lots of examples of trials now being undertaken in social care settings, whether that's a social care intervention or whether that's, for example, a public health intervention being implemented or delivered to members of the public in distress or in vulnerable circumstances. And the next couple of slides really just demonstrate some of the activity being undertaken locally, which are the application of randomised controlled trial methodology with underserved populations. So firstly, homeless populations. Colleagues within my own centre, James White and Becky Cannings-John, have led with colleagues in other parts of the university, Pete Mackey and elsewhere, on the application of randomised controlled trials for study of interventions to support homeless people. So this is really doing trials in often quite difficult circumstances. The second example of local expertise and innovation using randomised control methodologies with social care populations is that of intellectual disability and autism. And I just want to acknowledge my colleague Rachel, who's the director of the Brain Health and Mental Wellbeing Division in my own centre, who, along with colleagues in England, have run a series of studies which have been addressing different forms of support that have been developed to support both child and adult populations of people with learning disabilities. So, and I think that both for the homelessness example and the intellectual disability example, really good examples of local expertise which have been, which are available and working in these populations. And then finally, a bit closer to home for me is children's social care. I mentioned David and the social workers in school trial that he reported earlier this year, which was delivered in combination with researchers from my own centre, in the Centre for Trials Research, and particular researchers involved in these studies include Yvonne and Eleanor from CTR. And one of the examples that I'm going to talk about in a little bit more detail is the confidence and care trial, which was managed by Eleanor a few years ago, which evaluated training intervention for foster carers. So plenty of examples, actually, when you look around you, of randomised controlled trials being used to evaluate interventions in social care settings and social care populations. But we're usually talking about interventions in social care which are complex, and these provide a number of challenges for undertaking trials. These interventions are likely to feature multiple components. They might require some tailoring to deliver. They may operate and be evaluated at multiple levels and on a range of different outcomes. Recruiting participants into such studies may also be particularly challenging. For example, how we might want to engage with families, with practitioners, and in community-based settings. So recruitment is often a key focus to address in designing social care trials. Randomisation, as I've already mentioned, is something that does cause some concerns for stakeholders, and I think that as a methodologist we do need to be aware of that, and also I think sympathetic to that idea, and realise that there are going to be some circumstances where actually randomisation is not going to be feasible, and we may need to look at other approaches. And I'm not going to describe those other approaches, for example, natural experiments or quasi-experimental designs, but just to recognise that there are other methodologies that would be appropriate to use in circumstances where we feel that we cannot actually randomise. Another challenge that we commonly see in evaluating complex interventions, as would be commonly the case in social care trials, is data collection. And one of the key issues here, I think, is the paucity of high quality validated measures to use in these studies, and how we also achieve baseline data collection and follow up. Interpreting results and trying to understand differences between outcomes for which we have statistically significant findings, but may or may not prove to be meaningfully important for participants is also key. And then we have an issue generally in trials about the need to be publishing trials, even in circumstances where they produce negative results. I'll say a little bit more about that in a sec. So what I want to do really was just use one example of a trial that we undertook a few years ago, the Confidence and Care study, to look at some of the features of designing and delivering a randomised controlled trial in a social care setting. And this is an evaluation that we undertook a few years ago of a training programme which was targeted at foster carers in Wales. And this training programme was delivered through group-based sessions. There were 12 sessions over the course of a school term. And these were delivered by a consortium of third sector providers. So we actually partnered up with 4 or 5 third sector organisations who delivered the intervention, and we were the evaluation partner in that. And this was delivered to just over 300 foster carers across Wales. And these foster carers were both operating and coordinated by local authorities as well as independent fostering providers. As part of this study, we included a pilot phase and also an integrated process evaluation to understand a little bit more about some of the key features of the intervention and its evaluation. And I'll say a little bit more about what we found from that process evaluation. This was big lottery funded, and importantly, the recruitment into this study was supplemented and supported by researchers from Health and Care Research Wales own team. And this was the first time that that team, who would normally be recruiting patients into healthcare studies, had ever worked on a social care trial. So we took this as an opportunity to understand a little bit more about their experiences of recruiting for the first time in this particular setting. In our pilot phase, we took the opportunity to look at how we might optimise recruitment, and so quite a lot of our consideration at the time was what we could do to make to reduce the burden on potential participants while still retaining rigour to the essential study design. And the first option that we applied was what we described as decoupling the baseline assessment in the trial from the random allocation. So not allocating people immediately into either to receive the intervention or to go into a control arm. And this allowed us more time to recruit participants into the groups. A second choice that we made was to adjust the allocation ratio we used in that trial. So we started off with a 1-to-1 allocation, so you had an equal, every person recruited in the study had an equal chance to be entered into the intervention arm or to go into the control arm. And one of the challenges that presented to us, because recruitment rates were relatively low, was that we had difficulty filling the training groups. So we had a specification of between 8 and 12 foster carers needed to be recruited and included in a training group, and we were struggling to reach that reach that mark. So by adjusting the allocation ratio, we increased the likelihood of being able to fill those training groups. The third choice we made was about increasing the duration of the participant identification phase. We started off, I think, around about, we gave ourselves up to 2 months to reach out to potential participants in the study and sign them up so that they could undertake or be enrolled in the next wave of training. And we had several waves of training that we evaluated over the course of several months. So we found that was insufficient, and we increased that up to 4 months. So that just gave us more time to contact and gain responses from potential participants. We also did quite a lot of work very early on to improve the materials that we had originally drafted to use to encourage people to take part in the study. And this, I think, in part was about us as methodologists who were more used to working, some of us in other settings, to actually tailor the messaging and the presentation and the content of that material better to the study population. So I think that there was a degree of naivety on my part and on the team in terms of how we made this study attractive and accessible to potential study participants. And I think that's something that we kind of learn in each new study, that there are different ways of conveying those messages in an accessible format to potential participants. And then, rather than simply just sending out blanket emails or contacts to all listed foster carers in every local authority, we also supplemented that with a list of potentially eligible foster carers that were provided to us by those local authorities to allow us to better target those individuals. But by making these choices, there are some consequences. So, for example, if we change the allocation ratio that we use in the trial from 1-to-1 to 2-to-1, it does mean that we actually have to recruit more people into the study overall to ensure that we had adequate power. So, in making any of these choices, there are some consequences that we would need to be aware of. I'll just skip over that. In the process of evaluation, we took the opportunity to talk to those people who have been involved in actually recruiting foster carers into the study, and we did this through a couple of focus groups, and also we undertook a focus group with carers themselves. We undertook interviews with the people delivering the training, who were trained social workers, as well as participant foster carers and also a small number of non-participant foster carers, so people who would have been approached to take part in the study but who declined. We also spoke to social workers from individual local authorities as well. And this was true, and this was particularly focused on the challenges of recruiting into the trial. And what we found, that the sort of key findings from this evaluation was that the sorts of things that were really having a strong influence on people's decision to participate, firstly related to features of the intervention itself. So this was an intervention that was being delivered over a couple of hours at lunchtime every week for 12 weeks during a school term. So there were aspects of that which made it attractive to some foster carers, and there was quite a lot of enthusiasm generally for amongst the foster carers to receive additional training. But there were some practical aspects of the delivery of the intervention which was off-putting for some people. We also found that there were aspects of the communication from the trial team to providers, to the social workers in each local authority, that was off-putting as well. So and misconceptions about what we were trying to do, who we were trying to include, what the findings from the study would be used to achieve. So some miscommunication or ways that we could address communication to improve recruitment in the future. One of the things that was most influential was our ability to have or the recruiters to have direct contact with foster carers. So where we were trying to cascade information to potential study participants through various agencies, that extended line of communication had the potential to break down. So where there were opportunities to more directly speak to potential study participants, we were where those opportunities arose, we sought to maximise those. We also found that there were some communication challenges between the central trial team based in our centre and the field-based recruiting staff, and I'll say a little bit more about that in a sec. But there was a period of adjustment where we communicated with them about what we were trying to do, and it took a little bit of time for us to actually get onto the same page. And one of the things that really made the difference there was we brought in some of the social workers providing the training to run some educational sessions with our recruiting staff, and that really, I think, made a big difference in that particular study. And there were also some perceived differences in the way that we recruited and operated studies in a healthcare setting and in a social care setting, and I'll say a little bit more about that in a sec. But that has the potential to introduce some barriers into our recruitment process. So just going to pick up on some of the quotes that we had from the process evaluation, which talked to some of those points. First was a comment from a social worker who expressed, I think, a common sentiment about the motivation of local practitioners to ensure that their clients, their foster carers, got access to the training, which I think is completely understandable. But there was also frustration then when that didn't happen because of the random allocation process. We knew that was off-putting, and I guess part of our strategy would have been to continually reinforce why we feel that in this particular study design, random allocation was essential. But that was clearly a source of frustration for the social workers, and understandably so. This study was undertaken prior to the COVID pandemic, but we moved in our recruitment approach from direct recruitment, face-to-face recruitment, to remote recruitment by the phone, and our recruiting staff initially found this quite problematic. This was something that they were not used to doing. It was uncommon in their world, but actually, once they had exposure to that, once we had reassured them that this was both ethically and practically sensible to do, then they found actually this was a much better system for them. And of course, remote recruitment into studies is now becoming much more common. And this was one early example of where we had to do that out of necessity. And we found that some of the challenges for those recruiting into the studies was that they were encountering issues, concerns from foster carers about their care for foster children, which they hadn't encountered before and which they, in some cases, found quite distressing. So the recruiting staff new to this environment were encountering situations and topics which they were unfamiliar with. So again, the input that they received from the social workers in their training session, I think, was quite helpful with that. And then finally, what we found was that there was actually quite a lot of interest and support from Healthcare Research Wales as an organisation to support recruitment into these types of studies. So in some ways, this was an early leader for using those recruitment staff in a social care setting. And by the end of the study, they were really enthusiastic about this new role for them. So that's just one experience of undertaking trials in the social care setting. And the next couple of slides really about what happens when social care or trials in social care may not produce positive findings, in that we find an intervention effect. And there has been a question raised about whether trials in social care are more likely to have null findings compared to other trials, for example, in clinical settings. And indeed, in the trial that I just mentioned, we found some positive effects of the intervention, but we didn't find a difference on the primary outcome. So that's an example of perhaps of where we have some null findings. But in fact, in other contexts, we find that there may also be high or increased percentages of null findings in studies over time. So in fact, in both clinical settings, this subject has been addressed. You know, are we more likely now to have null effects in large effectiveness trials? In education, the same question has been asked about the frequency of null results arising from randomised control trials, and also in prevention science. So there's a general feeling that actually the proportion of studies where you end up having null findings is increasing, and also an intention really to learn from that. So where you have null findings, what can we nevertheless learn from the fact that we have undertaken that trial? But there are some really good potential explanations for why over time we might see that the proportion of studies presenting with null findings has increased. The first of this is actually that there's been simply an increased rigour in the conduct and reporting of randomised control trials over time, whether that's in healthcare or in social care. So the advent of protocols being published, the development of a priori analysis plans, and the a priori specification and prioritisation of outcomes. All these things have ensured that we undertake more rigorous studies, and in doing so, I think will reduce the incidence of studies which produce spurious positive results. Also, we should recognise that services as business as usual, services as usual, are also improving, partly informed by the results and evidence from earlier trials. This is something called the rising tide phenomenon. So what we're comparing an intervention to is also improving, which decreases our ability to show incremental benefit. We also find that there are more trials which are effectively replication studies of the same intervention in new contexts. And of course, taking an existing intervention and applying that in a new context is no guarantee that it will work there. And indeed, that new context may be, or the intervention may be unfavourable for that new context. It's also the case that there are probably more independent trials, that is, trials being delivered by people who are independent of those individuals who have developed the intervention themselves. And so that greater degree of independence and objectivity can also lead to reductions in the rates of positive findings. We also find that the final point there is that those providing services and interventions are under greater pressure now to generate evidence to support commissioning and purchasing decisions for those interventions, and this can actually lead to attempts to perhaps prematurely evaluate that intervention in a trial without having gone through some of the necessary developmental stages. So I can't actually answer the question about whether null trials are more likely in social care, but we should recognise that null trials are actually common in lots of other settings too, and there are some clear reasons why that might be the case. So I mentioned that preparatory work. I'll just say a little bit about what we might do to establish feasibility before we progress to a definitive trial, and this is about preparing well. And this citation is from the MRC's framework for the evaluation of complex interventions, which, although focused on, in particular, public health and healthcare, I think is equally applicable to social care as well. That there's often been too strong a focus on moving directly to the main evaluation without going through the necessary phase of developing and piloting either the evaluation design or the intervention, and that if you fail to do that, you're increasing the likelihood that your definitive trial will be effective. For those of you who may be less familiar with the concept of feasibility trials in the setting, if we look at the centre of that figure, this is the main trial. This is the definitive effectiveness evaluation, but there is activity that has to happen really before that to establish the feasibility, and these have been variously termed and comprise different methodologies such as randomised pilots, non-randomised pilot studies, and other forms of feasibility study. So if we were to jump too quickly into a definitive intervention evaluation, we miss some of these important processes that we need to proceed through. And I think that's been recognised, particularly in healthcare, the importance of doing that solid pilot feasibility phase. And some of the problems I think we have seen in healthcare is when we haven't taken the time or have the opportunity to do that solid work. And what we might be looking at to achieve in those feasibility stages are to really get a handle on two things. That's the feasibility of the intervention itself, its acceptability to the recipients of the intervention and those who are going to be delivering it. So is there a sound theory of change which underpins the intervention? Does it have a logic model? Is it something that can actually be delivered in practice to sufficient numbers of people? And then the feasibility and acceptability of the evaluation design itself. A lot of focus has been on that in recent years. Can we collect the data that we need to answer our study question? Can we randomise? Can we recruit? And can we retain participants in the study? So both focusing on the intervention and the evaluation design are valid objectives for feasibility trials, and there's an emerging and now quite substantial literature on how you go about designing feasibility studies. And there are a wide range of uncertainties that you might address, and I'm not going to go through these, but these just are a selection of some of the uncertainties that you would be keen to address in a feasibility stage. So what help is out there for people who are interested in undertaking randomised control trials in social care? The first thing I wanted to just point to was the methodological partnership that already exists within the UK in relation to trials methodology. And this is effectively a partnership across a large number of universities and brings together quite a large body of expertise on undertaking trials. And most of that probably is in the context of healthcare and healthcare evaluations, but not exclusively so. So there are many members of these working groups which look at different features of undertaking trials, which who are operating and undertaking studies in social care. I'll just pick on a couple of examples, the first of which is on informatics. So rather than collecting data directly from participants in social care trials, there's an increased interest in using existing data that might exist already in local authority records, for example, or in education records. And some of the key questions for us as methodologists and people who are designing trials in social care is how can we access those data? What quality is it? And what utility does it have for including as part of the study design in social care trials? And I'm really pleased to say that Cardiff has been something of a lead on this, and local expertise within my own centre has contributed to outputs as shown on this slide about some of the challenges of accessing routinely collected data from multiple providers in the UK, and also some of the potential issues that might be involved when accessing particularly sensitive data that might exist in social care records, like data relating to maltreatment outcomes. And work we're currently undertaking as part of a 5-year project funded by HDR UK with Fiona Lugwidger and Rob Truby in my own centre is about developing resources for trialists who want to use routine data as part of their trial design. Its starting point for this work is actually healthcare, but I think that most of what we're going to be producing and making available as training resources for researchers will be readily transferable into social care settings. So what we will be developing over 5 years are a series of training modules made accessible for free to researchers who want to be using routine data more as part of their study design. The other thing I think that it's important to mention as part of the work of this partnership is that of trial conduct. And in this specific instance, the role of participant and public involvement. And again, expertise within my own centre, Vicky Shepherd, has been leading the way on how we co-produce solutions with the public when designing studies and delivering them both within social care and in healthcare settings. And you see an example here of one of the outputs from Vicky's studies, which has been using public involvement to inform the process of proxy consent in social care, in social and healthcare studies. Of course, there are key centres that you may want to talk to in developing your own ideas for studies. Cascade, the Children's Social Care Research Centre, and CARE, the new HCRW funded Centre for Adult Social Care Research are probably the two most prominent examples. So if you want to know more about how to design your study and work in partnership with researchers who know the field or have knowledge of the field, then I would be encouraging you to speak to them and also to our researchers in our own centre. So if you're looking for support for designing your trial, I would certainly be encouraging you to pick up the phone or send us an email in CTR. And one of the underpinning sort of values that we express as a centre is that we need to be generating evidence no matter what the circumstances of the individual is concerned. So everyone, regardless who they are, where they live, deserves the best health and care, and our role as researchers is to generate evidence to make that happen. If you want to know more about how we can help you, then please do go to our website. There is a collaboration form which we make available to you. We have an open door policy for good ideas. So although we have themes within our divisions in the centre, you can actually talk to us about any research idea that you might have. We might be the right centre to take that forward with you, but if not, we would hope to be able to channel you to experts who may be able to help you. But in the first instance, if you come to us, we will see how we can provide you with support. So in summary, I think that looking around, there may be more trials in social care than you think. But we should recognise that doing high quality trials in social care and in any setting where we're trying to evaluate complex interventions does have difficulties. But then I don't think I've ever worked on a trial where the trial team at some point didn't regard it as problematic. So, and we need to be, I suppose, cute in the way that we tailor methods to meet the needs of the setting and the study population. And preparatory work is essential. So if we progress too early to a definitive study, we're likely to fall foul of that. There is plenty of local and national expertise available, and I think probably quite a high degree of willingness to support and work with you with your ideas. And that's it from me.